So let's look at another disease that mimic tuberculosis. The first case we had was a case of sarcoidosis. Prior to the time patient came here, she has had treatment for tuberculosis. The problem with second time was that somebody else, she went on that clinic, they wanted to treat her again for tuberculosis. And she felt, this thing never helped me. It never really helped. By the time she came here, she was really tired of the whole thing. She was even not taking her diabetic drug again. Because she was tired of the whole thing. She wasn't getting better. Fever continued, weight loss continued. Her husband was afraid that I think she had HIV or what. So it became a really problem. But by the time she had lymph nodes, you can see those lymph nodes. So what are we waiting for? Instead of doing, so we repeated all those tests, there was nothing there. So we had to go and do a lymph node biopsy. So sarcoidosis was a culprit, and it's quite a common to this environment that sarcoidosis and tuberculosis, they look alike, and they call tuberculosis a mimicker. It mimics tuberculosis so much.
In the department, we've been seeing a lot, or in the hospital generally, cough has been one of the major reasons why people come to the hospital. And we noticed that this cough is most of the time associated with systemic symptoms. Cough is actually a symptom, not a disease. And because of this, we have two cases to present to you, after which we will discuss symptoms and things around the presentation.
So my first summary is Mrs. S.O. She's a 52-year-old woman. She presented with a 3-month history of a right upper arm swelling, left-sided chest pain, and also multiple nodular swelling, which involved her neck, the pericular region, the axilla, and also her upper limb. She also had associated symptoms like weight loss, fever, night sweats, and also poor appetite. At presentation, there was no cough. However, prior to presentation, a long-standing history of a chronic cough, and at some point, she was also treated for pulmonary.
In countries with high burden of tuberculosis, such as Nigeria, and every patient presenting with this chronic cough should therefore be evaluated for tuberculosis. While recognizing the several other diseases that may be present similarly, the two patients that we discussed, they actually came with chronic cough and with some other systemic symptoms. However, during evaluation, it was found out that they have some other medical conditions. So, by way of definition, chronic cough is defined as a cough that lasts greater or equals to 8 weeks in adults, greater or equals to 4 weeks in children. And this symptom, there are some symptoms that are associated with this cough. One of them is fever. We have drenching night sweats, weight loss, fatigue. Some people come down with malaise, loss of appetite, hemoptysis, that could be chest pain or breathlessness. These are symptoms. They are usually as a result of underlying infection, inflammatory reaction that are taking place in the process. When a patient comes to you and tell you that, doctor, or I've been having this cough that is high grade, with associated fever, with drenching night sweat, you should be suspecting tuberculosis. There could also be weight loss, hemoptysis, that is coughing out of blood, chest pain with progressive weakness. The lung cancer has been one of the reasons that people come down with chronic cough. And we notice that in these people with lung cancer, it comes in different form. The non-small cell lung cancer and the small cell lung cancer. So this patient, usually their own cough comes with production of blood. There could be unilateral wheeze, and they are found in people with history of heavy smoking. This patient, when you ask them, you notice that they smoke a lot, and they will have been on it for years.
So we start by looking at the cough. Generally, cough is a common thing in the family care setting. and it become one of the 4 major common presentation in family medicine clinic. It's not a disease but a symptom. Chronic cough lasting over 8 weeks in adults or 4 weeks in children is significant. It needs to be explored. And when cough is accompanied with systemic symptoms such as fever, weight loss, or night sweat, or fatigue, it indicates a serious underlying condition. So when you have somebody coughing, as I said, sometimes people may be coughing because of asthma, allergic cough, post-viral syndromes, no problem. But when there are systemic symptoms, maybe is losing weight, is getting fatigue, is breathless, then you need to be more cautious and investigate thoroughly. Don't just assume it's allergy. So, what are the common causes of chronic cough? One of them is tuberculosis. Top most of the list. In our environment, tuberculosis is endemic. So, even the policy now is that anybody that coughs more than 2 weeks should have a chest X-ray done. Anybody coughs more than 2 weeks, irrespective of what you think in terms of whether it's post-viral or allergy, except you know the person to be an allergic patient. When it's asthmatic, you know, no problem. But if you are not sure, please always do a chest X-ray after 2 weeks. There is a bi-directional relationship between tuberculosis and diabetes. So, it has been discovered that one of them, either of the two, present in the patient predisposes him or her to developing the other case. If somebody has tuberculosis, he has high tendency of developing diabetes. If somebody has diabetes, he has high tendency of developing tuberculosis. So there is the direct relationship between two of them. And why is it so? It has been discovered that in the immune system, the people that have tuberculosis, let's start with tuberculosis. People that have tuberculosis, they have issues of an high inflammatory state. A person that has tuberculosis is undergoing high inflammatory state. And that means that a lot of cytokines are being produced, leading to anti-insulin hormones, which eventually lead to insulin resistance. So it has been told if somebody has tuberculosis, the advice is that you should screen them for diabetes. From the beginning, you screen them for diabetes, not just for HIV alone. You check them for tuberculosis. And subsequently, you also, after treatment, you follow them up for 2 reasons. One, so people are diabetic, but they are not diagnosed. So when you are seeing them for the first time, check it out. Number 2, because of the inflammatory process, they have an element of insulin resistance going on. So it's quite not uncommon to see people that have tuberculosis having some element of insulin resistance, pre-diabetes, even or have absolute diabetes. So when you notice anything, either with diet modification or you can use medication when necessary. But subsequently after they finish their tuberculosis treatment after 6 months, you follow them up because some of them may end up being free. So at the beginning you may say, oh, about 70% of them have diabetes. But when you screen thereafter, you follow them up after the treatment, you find about 20-30% of them will be free of diabetes. So it means that they're not diabetic, but it's the TB that is led to diabetes.